So I will give image credit to Dinos and Comics, which is literally constant rumination themes. So it just makes me so happy. This is going to be our practical guide, kind of the overview of the whole treatment from top to bottom. And you will want to pick up this book here, which is basically the guide for rumination-focused CBT, including the theory and the research behind it. The research continues to bear out, and I will continue to loop back to the research, which has been going on for at least the past 30 years. I'll tell you just very briefly about my journey with learning RF-CBT, what rumination is and why we need to target it, who is clinically appropriate for RF-CBT, what the key principles are of the treatment, and then we're going to do this step-by-step guide, and we're going to try and cover this full overview. So I'll try and go quicker through the front end so that we can spend more time on how we do orientation goal setting, the rumination assessment, the functional analysis of rumination, and then the functional analysis of variability, the if-then plan, and then experiential exercises, guided discovery, and practice. So these are the steps of the full intervention, which is typically between about 12 to 14 sessions. So just about my journey. As you all know, I have a couple of jobs, both working at the Utah Center for Evidence-Based Treatment and on the faculty of the University of Oregon. And my third job has been learning rumination-focused CBT from the treatment developer, Ed Watkins. It really is quite a cool thing to learn a therapy from the treatment developer, because as their thinking is evolving, you get to evolve. And so from the beginning of my training to where the therapy is at now, it's gotten increasingly experiential. What looks to be on its surface, reading the book, a fairly traditional cognitive behavioral therapy is in fact much different from a cognitive type CBT. So although it is targeting thought, what it is really targeting is habitual thought. And habitual thought is tricky to target, as we'll figure out. And so you really have to get into the experience in order to identify it. So let's get into what is rumination. And I love this little cartoon. Netflix says, "Are you still watching?" And he says, "No." And he says, "But I cannot be left alone with my thoughts." So a lot of what people do when they are first figuring out how to cope with rumination, their number one skill is distraction. So just throwing yourself into Netflix or other things that pull you out of your mind, but don't really give you any alternate set of thoughts, experiences, habits, or behaviors. Rumination is defined as recurrent dwelling on feelings, problems, upsetting events, and negative aspects of the self. And people will do all of these things, but often you will have one that they do more. So some people will tend to spiral more around problems or upsetting events, and others more on negative aspects of themselves. But a lot of these times, these things are all wrapped together and affect one another. So who is a good fit for RF-CBT? Anyone with an anxiety disorder, especially generalized anxiety disorder, depression, suicidal or self-harming individuals, anyone with obsessive compulsive or body dysmorphic disorders, or anyone who recognizes that they want to reduce worry, rumination, or any form of overthinking. And what I want to say about this is that the evidence so far suggests that rumination emerges before these disorders. So earlier in development, in the course of normal worry development, rumination starts. And even after we do a successful treatment for a lot of these disorders, the rumination will stay. So one of the important things about treating rumination is that it may prevent the emergence of new disorders or the reemergence of a disorder that's already been treated. The people who are not a good fit are those who are unwilling to work on rumination. So this happens. Sometimes people are really it's like touching a hot stove. They're really uncomfortable with diving into this, or they just don't have a lot of rumination. There are some people who have that presentation. Probably as with most evidence-based therapies, if you have a lot of high life chaos, you really need to sort of get a set of behavioral skills in place to make sure things like showing up to session on time, being able to do the full session, being able to complete homework are in place. And then dissociative disorders are also not a good fit because you need to be able to sort of experientially go into your thought. One other thought before we move on to the next slide. A lot of times suicidality is thought of as its own unique process, but I think that suicide and suicidal thoughts are often very similar to rumination. They're repetitive, negative thought about problems or negative thoughts about oneself, and they serve an avoidance function. So I do think that this is a good fit for people with PTSD or traumatic stress related disorders. I would have to look back at the literature a bit to see if there's any recommendation on order of treatments, like if a person should get a standard PTSD treatment before diving into related work, because it is, both are intense, and going into the rumination, if you have a lot of trauma content, could inadvertently be a bit more of an exposure therapy than a person is prepared for. So my gut instinct clinically is that you would probably want to get the PTSD symptoms lowered and then start in on this as a way of preventing relapse of those types of thoughts. Okay, so now let's talk about what does the session by session pace of RF-CBT look like. And I like this comic here because a lot of times people who are ruminating will have social struggles. The rumination will affect friendships and deep relationships, and that's because the content of being in one's head so much can really leave people wondering, like, do you like me? Are we friends? And so I related to this. Okay, there are 8 key principles before we get to the specific session by session that infuse all of the sessions. So the first is to normalize the patient's experience of rumination. So I love that we started with people sharing a bit about their own experiences, often of rumination, and that normalizing is really, really important. So continuing to talk about the fact that everyone does this to some degree, and that it is in fact very similar to problem solving, and it has some benefits. There are some perks to being able to intellectualize and think about one's problems, and it often sort of goes beyond what we would want. The other thing is that rumination needs to be an explicit target of therapy. So one of the things that you'll see as we go through this therapy is that it is not problem of the week therapy. And in fact, you will often go back to the habitual forms of rumination over whatever is happening that particular week. So if the client doesn't know that rumination is the target, they may feel invalidated. Like, why are we coming back to this thing when I have this or that problem that emerged in this particular week? One of the core principles is what's called ACEs, which is that the goal is to encourage behavior that is active, concrete, experiential, and specific. So rumination is vague, it's in one's mind, it is not in the moment, and all of the skills and strategies that we're applying are going to be the opposite of that. And many of you are familiar with the concept of functional analysis. It's embedded in basically especially every third wave CBT. The functional analysis here is quite different, and we'll talk about ways in which it is different in RF-CBT relative to dialectical behavior therapy, for example, or other CBTs where we do functional analysis. It does have an ABC approach where you are getting at antecedents, behaviors, and consequences, but really it is so much more experiential. You're also going to be linking behaviors to triggers and warning signs. So we'll talk about how triggers are external things that happen, and warning signs are internal experiences or sensations that let us know that we're about to start down a rumination spiral, or that we've already begun. It is designed to target the ruminative habit, and as you may know, the only way to change habits is through repetition and practice. So if you're not doing stuff in between sessions, you're not going to be getting the benefits of the therapy. It is important to be working on shifting toward an adaptive style of thinking. And of course, like all of our effective therapies, there is important non-specific factors, your warmth, empathy, optimism, etc. And how does this get implemented within the session? This is what's called the E6 rule. The first is that in almost every session, you're going to be exploring experience. The first half of the therapy is very heavy on exploring experience. You're going to really try and understand what the ruminative pattern is for that person, what their thoughts are. And then you're going to experiment with the experience. So that means that you don't leave a session without doing something together. You're always doing something active and experiential. And then the final principle is exercise and engage, so that the person is learning how to do the work in the session that they'll do between the sessions. And this right here, this has changed my work with every evidence-based therapy. I really think that our training models often inadvertently train us to do talk therapy, right? So to talk about what the struggles are and then be like, okay, good, now that we've got all this insight, go out and do something different. And that often leaves people like, okay, without any idea of how to do something different. The E6 rule has definitely infused all of my work, where I'm like, if we haven't tried it in session, I am pretty sure that there's a very low probability that the person will try it in their actual life. So it's made me a braver therapist. Now we're going into the sessions. Session 1 is orientation and goal setting. And like all of our EBTs, that first session is critical. A lot of what it is rapport building, but also laying the groundwork for the idea that the therapy will be structured, that there will be work to do between sessions, and making sure that they understand what rumination is and that it will be a target of the therapy. To get to that place of commitment, you are using a lot of guided discovery. So asking the person about their own overthinking, times when they overthink, ways in which overthinking has affected their life, and you're using that to help them build their goals. So you're getting a general sense, first of all, the frequency, that's supposed to say context, not contests. So a general sense of the rumination, the frequency, the consequences, and the contexts in which rumination happens. One thing that came up as we were chatting, but that is in general a thing, is that people often ruminate in bed. And the reason for that being a common context of rumination is that people have finally gotten all of the distractions away, and they're laying there, and the one task is to like stop thinking and go to sleep, and the brain is like, nah, I'm not here for that. I'm going to think about every single problem you had all day long. And people will often ruminate for quite a long time at night. The one important thing is to determine if the rumination is habitual, a maintaining problem for the patient, and thus, that's also supposed to say patient. No idea what happened on this slide, and thus worth targeting. So if rumination is not one of their core problems, then going down the road of this therapy is obviously not a good fit. We tend to drop the word rumination pretty quickly unless that's a word that the patient uses. So we'll use their own term. Overthinking is a really common one. Worrying is another common one. So if a person is saying overthinking or worrying or brooding or whatever, we'll try and speak in their terms and with their examples. The habit. So there's an article that I'll share with you all either between this week and next or next week that looked at meta-analysis of therapies and targeting what thing was the most effective. And it turns out that of all the things you can target, habits is the most effective. If you're targeting habits, that was the most effective thing across a meta-analysis of psychotherapy studies. So I thought that was really cool to see. And rumination is a habit. So the example that we often use, usually I'll start with, do you have any habits, right? Good or bad. So things like brushing one's teeth might be a habit, but people might have negative habits like chewing on their hair or biting their nails or whatever. And biting on one's nails is a really good example to use with a person, because when a person bites on their nails, they often don't even realize they're doing it. So it starts, when maybe they're a little bit worried or stressed about something and they don't even notice that they're chewing on their nails until they tear or something happens and all of a sudden it hurts. And this is the same with ruminative thought, is a lot of times when we're ruminating or worrying, we will just be background, low-level thoughts that we don't even notice are happening. And we don't notice that series of thoughts is happening until all of a sudden a thought well, if I stepped in front of this train, no one would even notice. No one would even notice that I'm gone. And then all of a sudden people are like, whoa, I'm having this really terrible thought about myself, or you look so stupid in this outfit. Whatever the thought is, all of a sudden the person catches themselves ruminating, and it's painful. Oh, and then it's also good to start planting that seed about how it's a habit, because then you can say, well, have you ever changed a habit? Have you ever started a new one or gotten rid of an old one? And that helps people to recognize that, in fact, in order to change a habit, you have to have a really powerful new habit to put in its place. You don't just stop habitually walking to the fridge and opening a drink right after work without having a replacement behavior or some new behavior to put in its place. And the same is true with rumination. As you go through a lot of validation, normalizing, and feedback on the ruminative process and collaboratively agreeing on it as a treatment target. And as with all skills-based therapies, linking rumination to their, wow, typos galore, to the patient's goals. Like all CBTs, your therapy will have an agenda. On this session 2, you want to start with revisiting what they recall from the last session. So last session, we talked about your overthinking. Tell me what you remember. What did we talk about? What stuck with you? So really getting a sense of, like, do they understand rumination as the target, and do they want to target rumination? Then you're going to go into the rumination assessment. This is what we're going to work on probably next week, is the rumination assessment and doing an assessment with one another. The model of rumination, I'll show you that on the next slide. And revisit the client's goals to strengthen the association between rumination and the desired therapy outcome. And you will assign homework after this session. Okay, so what does the assessment look like? You're going to get all the key things. So how often is this happening? What is the person ruminating about? Usually people will have, I would say, 3 to 6 common areas of rumination focus. How long does their rumination last? For most people, it's at least 45 minutes when they get into a good rumination spiral. And then the where of rumination. And the context is where you do kind of your who, what, where, when, why. When do you find that you're worrying or ruminating more? At night, like I said, is common. After school for teenagers, there's this period of time where they're tired from schoolwork, but are like expected to be already working on their homework. And so that is a common window of time. What things make it better or worse? What do you notice about your feelings that might be warning signs? So mood tends to change along with rumination. And when that happens, that's a warning sign for a person. And situations, times, or places where it happens more often. The consequences, like I said, mood drops. A person gets sad or anxious. The activities will change. So a person might be more sedentary or stagnant. Their energy levels decrease, concentration is affected, sleep is missed, relationships are affected, confidence drops. And I put this in all big letters because rumination often, if not almost always, serves an avoidance function. So why does rumination appear right during the time when a kid is tired but knows they need to do homework? Is that the brain is like, I'd rather rehash all of my problems with my friend group today than sit down and do my homework. So if you think about basically anything that you're avoiding in your own life, parts of your work that you dislike, or whatever it may be, oftentimes rumination will fill in the spot where you could be doing that thing. You could jump up and start your day and get that, all that work done, but instead you sit there wondering why you ever chose to go in the career direction that you did in the first place. And then we also have developmental questions. So when did it start? Did you learn it from somewhere or someone? Most often people have other ruminators in their lives. So parents or friends that tend to worry and worry out loud. So that's really common. And I will say that working with teenagers, most people trace their rumination to somewhere between like 4th and 6th grade. So I think this is related to significant brain development during that time and the types of peer stressors that emerge. So bullying and other things, relational aggression tend to start happening in that 4th, 5th, 6th grade period of time. And kids don't yet have a lot of strategies for avoiding or stopping rumination. So after we do our assessment, we will often draw it out. And so we're going to try and list out the person's triggers. These are external things, right? So my mom said, you never clean anything around this house. So things that are said to you or that you experience out in the world. And then this is followed really closely by warning signs. So warning signs are the internal experiences that a person has that are affecting, that are part of the rumination spiral. So this might be like heart starts racing, shoulders get tense, or stomach starts to hurt, head starts to hurt. You know, find yourself just sitting on the floor of your room, not doing anything, sweaty palms. You start having thoughts like, I'm the worst. All of the elements of like, oh, this is a beginning of the spiral. And this is where the person is overthinking, worrying, or beginning to get stuck in the rumination. And as a person starts ruminating, they will have negative consequences that they'll identify. So a lot of times it might be irritability with people around them. They start getting kind of short or clippy with people, irritable with people in their lives, or they start crying or feeling sad, and then they're avoiding things. So like I said, for teens, this will often be homework or avoiding family or avoiding friends. And same for us, like as adults, we avoid work, we avoid cooking that healthy meal that we were planning to cook, avoid interacting with people that we want to interact with. So your homework assignment after the assessment is the rumination log. So the orientation is that an important part of the therapy is to spot times when you get stuck in your thoughts, ruminating, worrying, overthinking, overanalyzing, or dwelling, and times where you notice yourself avoiding things. And as I said, everything that you expect the client to do, you do with them. So you are going to fill out the first line of the rumination log with them in the session. So, okay, let's think of a time that you ruminated this past week. And they say, okay, it was Tuesday, and you put the date down. Where were you? One of the things you're doing by doing this in session is you're making it really clear that they don't need to write a novel to you. They just need enough to be able to come back to session and actually tell you the story of their rumination. So I was in bed, what happened right before it started, like my mom said something, I remembered this thing that happened earlier today at work. And then this next line is getting at your warning signs. So what did they feel? Tense, agitated, restless. Everyone's warning signs are a little bit different, but they are common experiences. And then what did you start thinking about? Like, what was the content of the rumination? Oh, I said that thing to my friend. I thought that I came across in this or that bad way. And then how did you feel after the rumination? So, usually negative feelings of some sort. And then I like this example of 2 hours because it's actually fairly common that rumination will last a couple of hours. And then you're continuing to reinforce that rumination, noticing it is step one. Awareness is the beginning. This will end up being our homework as well. So I will send you this list of questions to keep track of this week so you can catch a couple of episodes of your own rumination. Okay. Session 3 is where we will spend at least a couple weeks of our training. The functional analysis. It's so powerful and so different. And you're going to explore deeply the specifics of a person's rumination moment by moment by moment. You're going to slow it down, so slow. And here's the thing, you're going to do it in the present tense, not the past tense. So the way I like to orient people is that we're not remembering, we're re-experiencing the rumination. And that means that as I'm asking my questions, I'm asking them in the present tense, and we might spend 20 minutes on less than 2 minutes of a person's rumination spiral. So we'll practice this one a lot. I think without a training, you could not learn how to do this on your own. Like, it would be very hard to know what the style of the functional analysis is. You're going to focus on something that's recent and habitual. So whatever happened that week, the quote unquote drama of the week, that's not where we're going unless that sort of hot button issue that happened that week is exactly part of their usual habitual pattern. So that's where your session 2 assessment really helps you know what are the things they habitually ruminate about and what's something that was kind of a one-off thing that happened this week. So it will be something that is recent, often in the past week, but it's going to be like one of the habitual things. So you'll sometimes have to start with like looking at that rumination log and finding, the one of the 3 or 4, what's the one that's most like their typical pattern of rumination. You will set the scene just like you would for any experiential exercise. So if the person is in their room, you're going to have them close their eyes and describe what they could smell and see and taste and hear and feel, and like all of their senses, and what time of day or night was it, what's the lighting like. You're going to really get them into that moment before you start the second by second functional analysis. And this is where you're going to go, into everything that's happening moment by moment at a micro level. So what does this look like? Well, like I said, we'll spend a lot of time practicing it together as a group, but you will be in the present tense with your questions. So you're in your room, it's dark, you're under your blankets, you can hear your dog breathing on the floor. And what is the first thought that you're having? And then when you have that thought that, I can't believe I said that to my friend, what emotion is coming up for you? And as you're feeling that emotion, what do you notice in your body? Right? So you're having them relive, and you're going to ask about, and then what happened next? Sorry, I slipped into past tense. It's so easy to do, And then what happens next? What do you do? What are you doing next? And when you said that when you're saying that to yourself, what's your tone of voice? You can see how hard it is even to describe it without slipping into the past tense. So you're really linking each question. The idea of contextually bound questions is each question is following from the thing that happened before, the thought, the feeling, etc. I know we're low on time here, so we may end up doing some more of this next week. So just to hit this point of what this experiential functional analysis is like, is that it really is much more like exposure therapy than a chain analysis. People will often cry, and people will be shocked by their mental tone. They'll be horrified at the things that they say in their head that they would never say out loud to any other person, and with that kind of unkindness that they're saying it to themselves. So this session, it can be a place where people want to drop out of therapy because it's so intensely painful. So you want to make sure you have a good 10 minutes or 15 minutes of processing time afterwards, and that you can do another assignment of the rumination log so that you really kind of know that you have a good couple of sessions of functional analysis. And I do tend to tell people this is the hard part of the therapy, but we can't move forward with new skills until you've done this, because if you can't catch your rumination, you can't do anything about it.